It's 8:06. Good morning.
Morning po.
Maybe we can start.
Yes po.
So I'm running on battery only because walang kuryente dito sa San Juan. So let me just, I'll use my recording because I have no power right now. So let me just, okay, so good morning everyone. Yes, I'll be using, I'll be using a pre-recorded lecture for a review course in Philippine Obstetrics and Gynecologic Society. So our topic for today is pre-malignant and malignant conditions of the vulva and vagina. This will run for 45 minutes. So I hope the recording will play for the 68% left of my battery. Okay? So let me just pull up my slides. Ignore na lang na it's a review course in the Philippine Obstetrics and Gynecologic Society. This was made for OBGYNs and students. Can you see my slides?
Yes po, Doc.
This very interesting topic. By the way, my name is Richard Ronald Cacho, and I'm a gynecologic oncologist and also a member of the POGS Committee on Continuing Medical Education. I hope this review will be helpful for you to face the exams, okay, and ace your exams as well. Without further ado, let me start. Our topic today is pre-malignant and malignant conditions of the vulva. Let me pull up my slide. Okay, so as I've said, this is pre-malignant malignant conditions of the vulva. This is part of our first POGS online review course. Our learning objectives today is for this episode is to give you a brief overview of vulvar and vaginal cancer, a brief picture of the epidemiology and risk factors causing vulvar and vaginal cancer, as well as a brief description of the natural history and spread of vulvar and vaginal cancer. The different diagnostic measures will also be discussed, as well as the categories, histologic types, staging of vulvar and vaginal cancers. The different treatment strategies in the management of vulvar and vaginal cancer will also be discussed. Okay, so we'll be having a very long discussion today. Okay, so let us start first with the non-neoplastic epithelial disorders of the vulva, mga makakating mga lesions, lichen simplex chronicus. The presentation, reproductive and postmenopausal years. It occurs in the reproductive and postmenopausal years with history of atopy, allergy, signs and symptoms, pruritus, intense pruritus. Triggers of these condition are as follows: heat, moisture, pads, and topical agents. Located mainly in the labia majora, interlabial folds, outer aspects of the labia minora, and jugulis. The lesions looks like a chronic eczematous condition, and because of the intense pruritus, females usually scratch all the time, and it causes epithelial thickening and hyperkeratosis. Localized, they are localized, elevated, and well delineated. They are considered to be red plaque in dermatological terms. Under the microscope, you can see presence of hyperkeratosis, maraming keratin. No? Yan. Makapal ang keratin. And acanthosis or lengthening and distortion of retepegs. As you can see here, mahahaba ang retepegs. Parakeratosis may be present as well. With inflammatory reaction, if you look further under oil immersion, you will see a lot of lymphocytes and plasma cells. Treatment should be targeted towards underlying cause of irritation and pruritus. Minsan it's because of the soap or the underwear, so you have to get rid of that. No, minsan perfume. Okay, so pharmacologically, you can use topical steroid ointment, for example, triamcinolone 0.1% or hydrocortisone 2.5%. Generally, in 3 to 4 weeks, you can use that, and as well as you can also give some form of sleep aids because of the intense to alleviate kasi hindi nakakatulog ang mga babae ng simplex chronicus because of the intense pruritus. Okay? Now, let's go to lichen sclerosus, which is also a non-neoplastic epithelial disorder of the vulva. Bimodal ang occurrence ito. It can happen premenarcheal and postmenopausal sa mga bata at matatanda. Okay, signs and symptoms includes pruritus, burning, tearing, and dyspareunia. Napakakatinaw nito. Pag nakikita ka, if you see a patient with lichen sclerosus, they will say na ang sarap kamutin. Okay? The skin of the vulva is sprinkled like a cigarette paper or appears parchment-like. Synechia often develop stricture because of the chronic scratching. The vaginal mucosa is generally spared for lichen sclerosus. If you see some scaling in the vaginal mucosa, then that is not a lichen sclerosus. That is a giveaway clue, no? Okay. Lesion, chronic inflammatory, lymphocyte-mediated dermatosis. Autoimmune mechanism may be involved in lichen sclerosus, and this is a risk factor for invasive vulvar cancer. Lichen sclerosus is not cancer, but it is a risk factor for developing invasive vulvar cancer. 5% will develop VIN, or vulvar interepithelial neoplasia, which is a precursor for vulvar cancer, and 4.5% of patients over a mean of 10 years will develop VIN. 50 to 70% of squamous cell vulvar cancers occur in a background of lichen sclerosus. Okay, remember that lichen sclerosus can be a precursor for invasive vulvar cancer. Now, under the microscope, you will see hyperkeratosis, epithelial thickening with flattening of the retepegs. That is a clue under the microscope. Nagpa-flat ang retepegs. One line lang siya. Cytoplasmic vacuolization under the oil immersion objective of the basal layer cells and follicular plugging. Okay, treatment. There's no curative treatment for lichen sclerosus. The goal is symptom control. Control the itchiness, the pruritus. You can give super potent steroid ointment. Ito, alam natin lahat. Clobetasol propionate ointment, 0.05%. It is used nightly until resolution of symptoms, usually 8 to 12 weeks. Okay? Maintenance therapy is necessary 1 to 3 times per week. Okay? You should not be giving that in more than the indicated duration because it has an effect on the thickness of the epidermis of the vagina, of the vulva. Okay. Now, let's go to lichen planus. Lichen planus occurs at the age of 50 to 60s. It affects the oral mucosa, sa bibig, esophageal mucosa, skin, scalp, nails, and eyes. So, this condition does not only occur in the genital area, but also occurs or also can be found in the oral mucosa, esophageal mucosa, skin, so on. It will give the patient very itchy feeling, burning, pain, and edema. Labial agglutination and loss of architecture of the labial. facial mucosa is frequently involved. Unlike the lichen sclerosus, in these disorder causing chronic inflammation. Diagnosis, pathology, relationship between lichen planus and vulvar cancer is not as well established. So, lichen sclerosus, well established yan. Diba? 4% magiging VIM. Now, how do we treat lichen planus? Treatment is systemic disease present consultation with the dermatologist. They make give you systemic oral treatment. Both the potency steroid ointment in the form of clobetasol can be given at 0.05% concentration, applied nightly for 6 to 8. The epithelium is thickened and parakeratotic with elongated and anastomosing rete ridges. Abnormal cells are confined to the parabasal and basal portion, the rete pegs, with
Hindi po
little or no
nakashare yung
atypical in some parabasal
Ha?
layers.
Hindi
Basal
po
cells usually
nakashare
stain
yung review. Na-disconnect kayo
three,
ba?
and these are the immunohistochemical stains.
Okay,
The
wait lang.
positive cells extend beyond the basal layers into the upper layers of the epidermis. Probably a precursor of HPV negative vulvar diseases. So what are the risk factors for developing
Meron na?
epithelial neoplasia?
Yes po.
A human papilloma virus infection, cigarette smoking, immunodeficiency, or immunosuppression. Okay? It is important to note that vulvar lichen sclerosus is associated with differentiated type nerve. Okay? Again, human papilloma virus is a risk factor, infection with HPV, as well as cigarette smoking, immunodeficiency, or immunosuppression. Management options for vulvar epithelial neoplasia are as follows: wide local excision, skinning vulvectomy, ablative therapy, and topical treatment. Surgical excision is the mainstay of treatment for vulvar intraepithelial neoplasia. You can also give topical management in the form of imiquimod. Okay? This is available in the pharmacy. Okay? In mga butika around some Mercury and other known drugstores. This is applied topically to individual lesions, not to the entire vulva. You have to limit your application to the lesion itself. Course of therapy is 16 weeks or 4 months. Side effects would be inflammation on the application site and mild to moderate erythema or erosions. Okay? You can also give topical 5-fluorouracil, but this is not available yet here in the Philippines. When you use 5-FU or 5-fluorouracil, it causes a chemical disformation, the BIN lesion. The response rates could be as high as 75%, and the side effects would be burning, pain, inflammation, edema, and painful ulcerations, which are very common side effects for topical chemotherapeutic agents. Okay, now we proceed to vulvar cancer. Vulvar cancer is a very rare occurrence. It's a very rare female genital cancer. It occurs only in, it comprises 4 to 5% of female genital malignancies, and it is 0.6% of all female cancers. Wala pang 1%. Younger women, HPV-related pre-invasive disease, and history of tobacco use. For older women, lichen sclerosis pa rin, chronic vulvar dystrophies. Okay? Sometimes, because vulvar cancer is a disease of the old woman, it is very rare to see vulvar cancer among younger women. And if you see that, they are usually HPV related. Okay? These are the risk factors for vulvar cancer. Increasing age, so mas maganda, mas at risk. Pre-cancerous changes like your lichen sclerosis, HPV infection, 16, 18, and so on and so forth. Vaginal cancer or cervical cancer, sometimes they are metastatic lesions lang from a cervical cancer or vaginal cancer. Immunodeficiency and heavy cigarette smoking. Okay? Presentation, the number one, the most common sign or symptom of vulvar cancer is pruritus, makating-makati, and of course, a mass. An enlarging label mass. Other symptoms would be pain, bleeding, ulceration, dysuria, discharge that is foul smelling, and a groin mass. Okay? That groin mass can be a groin node enlargement or groin node metastasis. Okay? How do we biopsy vulvar lesions that are very suspicious for malignancy? We use Keys punch biopsy. Okay? Eto. This is the appearance of Keys punch biopsy. Supposed to be sharp ang edges nito. Not super sharp, but ano lang yan. I-didiin mo lang yan against the skin. Okay? Biopsy the vulva can be accomplished with these Keys dermal punch biopsy. Each area where a biopsy will be taken is usually infiltrated with local anesthesia. The punch is then rotated and downward pressure is applied so that the disc of tissue is circumcised. When the entire thickness of the skin has been incised, the specimen is elevated with forceps and removed with a sharp scissors. Usually, ang binabiopsy, the best area to biopsy will be the edges of the lesion so that you have a normal part and an abnormal part. Okay? Not the central part. Usually, the central part is necrotic. Okay? Imaging studies such as CT scan, MRI, radiographs may then be utilized in order to determine the extent of the disease. Most commonly, the spread pattern of vulvar carcinoma is by direct extension and through the lymphatics. Nodal involvement need to be established to finalize the treatment plan. Okay, this is the staging for vulvar cancer. Okay, stage 1, tumor confined to the vulva. Okay, 1A less than or equal to 2 centimeters, but no nodal metastasis. 1B more than 2 centimeters, pero walang nodal metastasis. Stage 2, tumor of any size with extension to adjacent perineal structure like the 1/3 of the lower urethra, 1/3 lower vagina, anus, but no nodal metastasis. Stage 3, tumor of any size with or without extension to adjacent perineal structure with positive inguinofemoral lymph nodes. Okay? 3A with 1 lymph node metastasis. Okay? That is greater than or equal to 5 millimeters. 1 to 2 lymph node metastases kung less than 5 millimeters. 3B with 2 or more lymph node metastases, which is 5 millimeters or more. 3 or more lymph node metastases that is less than 5 millimeters. 3C with positive nodes with extracapsular spread. Okay? Stage 4, tumor invades other regional or distant structures like two-thirds of the upper urethra and two-thirds of the upper vagina. Tumor in 4A, tumor invades any of the following: upper urethra and or vaginal mucosa, bladder mucosa, rectal mucosa, or fixed to pelvic bone, or fixed or ulcerated inguinofemoral lymph nodes. 4B, any distant metastases, including pelvic lymph node. Okay? So you study this one, no? Usually, ang mga lumalabas dyan, hindi na yung masyadong very complicated. Okay? Yan. This is just the stage 1 and stage 2 showing you in pictures. Okay? Stage 4, an extension to pelvic organs. Okay? The staging of vulvar cancer is surgical pathology. Number of lymph nodes, metastases, and extracapsular spread are predictive of survival regardless of laterality. So, yung lymph node involvement is very, very important. Very important prognostic factor. Okay? If the size of the lesion, these are the prognostic parameters. Size of the lesion, if it's less than 3 centimeter, usually 19% ang lymph node metastasis. So that means you don't need to memorize the percentages. It only means na kapag mas malaki, if the size is greater than 3, there is a higher incidence of lymph node metastasis. If it is poorly differentiated, higher chances of lymph node metastasis. If it invades more than 5 millimeters, higher lymph node metastasis. And if it's the lymphovascular space invasion is positive, higher chances of lymph node metastasis. Okay? So these are the 4 prognostic parameters. How do we manage vulvar cancer? For early stage, we do radical local excision or vulvectomy. For more advanced, we do modified radical excision or vulvectomy with sentinel node biopsy with or without inguinal node dissection. For advanced stage, na mahirap operahan or hindi na kayang operahan, we can do radiation concurrent with chemotherapy followed by limited surgery. Okay? So these are some of the techniques, no? Stanley Way, para siyang letter Y. Single incision technique. Isang incision lang na parang ulo ng tamaraw or kalabaw. And the other one is Hacker. Hacker pabilog with sparing of the anus. Okay? Wound breakdown is a common problem in vulvar cancer surgery. Okay? It occurs in more than 50%. Kasi because of soiling, from urination, from urine, and fecal materials. Okay? Sometimes complications such as lymphedema can happen in lymph disease. Okay, this is Hacker technique. And for advanced stage, we do radiation. We send the patient to radiation oncology for radiation and concomitant with chemotherapy, followed by limited surgery if there's an indication. Now, melanoma can happen in the vulva. Okay, I have seen cases in the past wherein there is really vulvar melanoma. This is very, very rare. Okay, pero you cannot miss the diagnosis because they appear black masses or blue-black masses. It is the second most common malignant neoplasm of the vulva. Arises from a lesion containing junctional or a compound nevus, yung mga moles nila. Pigmented and raised and may be ulcerated. The symptoms of vulvar melanoma are as follows: pruritus, bleeding, enlargement of pigmented area, and they are often misdiagnosed as undifferentiated squamous cell cancer, especially when a melanoma. Okay? If you are not sure of your diagnosis ng melanoma, you can ask for your chemistry stains. Okay, this is a very common question in the written and the oral exam. What are the immunohistochemistry stains that you request for melanoma? It is S100 and HMB antibody. Okay, Clark's level is the staging system for melanoma. Okay, yan lang, good to know. Clark's staging for melanoma. Okay, prognosis is related to size and lesion and depth of invasion. 5-year survival rates by histology, if there is a superficial spreading, 71%. If it is nodular, it's 38%. Radical local excision with a margin of 2 centimeters for thin lesions and 3 to 4 centimeters for thicker lesions for well-circumscribed melanomas. Okay, for Clark level 1 or 2, we do wide local excision. Lymphadenectomy is prognostic than therapeutic because if it's positive ang lymph node, it has a poorer prognosis. But it does not affect the survival rate. Okay? It is not therapeutic. Another vulvar cancer type is Bartholin's gland carcinoma. Okay? Mga Bartholin's gland sa mga babae, you have encountered already Bartholin's cyst where you need to muscularization. Okay? The differential here is Bartholin's cyst, no? Pero here kasi you can feel na it's solid, irregular. It is very rare, 1% of vulvar malignant neoplasm, and it occurs in mid-60s age of women. Finding of a mass or ulcerative lesion, it can also give you dyspareunia. Enlargement in Bartholin gland area in postmenopausal women should be considered a malignant neoplasm until proven otherwise. Almost half are squamous cell carcinoma. Okay? We do radical vulvectomy with a large, wide, extensive dissection around the gland and inguinal lymphadenectomy. When in doubt, ang isagot yung radical vulvectomy po, Bartholin's gland carcinoma. Pero I doubt if this will come out in the oral exam, but in the written exam, it's nice to know that the Bartholin's gland can be malignant also. Okay? Another vulvar cancer type is basal cell carcinoma. This is a disease of the very old woman. 1.4% of all vulvar cancers. The symptoms: itching, irritation, soreness, lesion that bleeds and seems to heal. Slowly increases in size, very indolent. Napakabagal niya. Anterior hair-bearing aspect of labia majora, local invasion, lymphatics rarely involved, wide local excision without need to evaluate regional lymph nodes for basal cell carcinoma. Okay? So, this is the last slide for vulvar cancer, and here are the key points or summary of vulvar cancer. Vulvar cancer is less common than other gynecologic malignancies, including uterine corpus, ovarian, and cervical cancer. In the United States, vulvar cancer is also less common than vaginal cancer. Squamous cell carcinoma is the most common histologic type of vulvar cancer, comprising at least 75% of cases. Other histologies include melanoma, basal cell carcinoma, Bartholin gland adenocarcinoma, sarcoma, and Paget disease. Paget disease is para siyang borderline malignant tumor of the vulva, and usually it's a systemic disease. If there's a question in your oral exam or written exam, Paget disease is more, you need to look at the systemic, the whole body of the woman, because sometimes there's a Paget disease in the breast. Okay? Human papillomavirus infection is associated with the majority of vulvar squamous cell carcinomas. In addition, vulvar lichen sclerosus is associated with an increased risk of vulvar cancer. Okay? Remember that, lichen sclerosus is associated with an increased risk of vulvar cancers. The majority of women present with an enlarging vulvar mass or ulcer, occasionally associated with bleeding, intense pruritus, or unoffensive discharge. Remember, pruritus and enlarging vulvar mass are the most common symptoms of vulvar cancer. Diagnostic biopsy in the form of key sponge should be taken from the edge of the tuba. Remember that. Treatment modalities depends on the stage, grade, type of histology, and lymph node metastasis. Early stage disease usually have a good prognosis. However, melanoma and other rare types pose a poorer prognosis. Okay, so this is a list of the summary. This is a list of the key points for vulvar cancer. Okay, and here are my references for this slide. Now let's go to the vagina. Pre-malignant and malignant conditions of the vagina. Okay, a typical vaginal adenosis. What is a typical vaginal adenosis or AVA? These are interepithelial vaginal dysplasia of glandular origin. Remember, the surface epithelium of vagina is different from the surface epithelium of the vulva. So vulva, it's a stratified squamous keratinized epithelium. But in the vagina, it's still stratified squamous, but it's not non-keratinized. Okay? Well-established associated with in utero ethyl sylvester DES exposure. But DES sa vagina, think of a typical vaginal adenosis. This is a precursor to DES-associated clear cell adenocarcinoma. Okay, remember that. Your vaginal intraepithelial neoplasia. For vulvar intraepithelial neoplasia, you call it vein. For vagina, it's vein. So vein 1, 2, 3 again. These are precursor lesions of the vaginal cancer. If it involves lower 1/3 of the epithelium, it's vein 1. It involves lower 2/3 of epithelium, vein 2. Vein 3 naman, pag it involves 2/3 or more than 2/3 of the epithelium. Okay? In 2012, the ISSBD again reclassified this. Vein 1, L-sil na. Vein 2, vein 3, H-sil. Now, vein, vaginal intraepithelial neoplasia. It is estimated at 0.2 to 0.3 cases per 100,000 women in the US. The average patient is between 43 and 60 years of age. Incidence of vaginal carcinoma in the US is estimated at 0.1 cases per 100,000 women. The incidence peaks at age 70 to 70 years. Okay? Vaginal intraepithelial neoplasia, vaginal cancer is very, very rare, no? But in the United States, vaginal cancer is more frequent than vulvar cancers, but both are very, very rare. Ganun din sa Pilipinas. Seldom lang kayong makakita ng mga vaginal cancer and vulvar cancer. Usually, most of the time, they are metastatic from a cervical cancer. They are former cervical cancer patients. Okay? Vein carcinoma inside of the vagina much less common than that of the cervix or vulva. Routine screening for vein and vaginal cancer is not recommended because of the low prevalence. Napaka-rare. Why create a screening program? Dapat ang screening program should be somewhat high ang prevalence or incidence. Pero vaginal cancer, very low ang incidence. So there's no routine screening program in vaginal cancer. 50 to 75% with vein tend to have either an antecedent or coexistent neoplasia in the lower genital tract. Patients who have been treated for disease in the cervix or vulva, vein can appear many years later, necessitating long-term follow-up. What are the risk factors for vein? Smoking, earlier age at first intercourse, increased number of sexual partners, human papillomavirus infection. Okay? 80 to 94% for vein and 60 to 65% for vaginal cancer. Usually, the serotype of human papillomavirus that causes vein and vaginal cancer are your 16 and 18. How do we diagnose vein? Pap smear. Through pap smear, patients with an abnormal pap test who do not have cervix or patients with abnormal pap test result in no cervical abnormality. Dapat clear ang cervix before you say that it's a vein. okay, or a vaginal lesion. Okay, you should uh, subject the patient to a very careful examination of the vaginal epithelium. Colposcopy may help, okay? More common in the upper third of vagina if there are aceto-white epithelium, mosaicism, punctation, pink blush appearance, and slightly granular tissue. How do we manage vein? We excise, we burn them through ice, topical therapy, and radiation ablations. Treated vein often recurs, nagre-recur sila oftentimes. Regardless of the treatment method, and there is no clear standard of treatment. Treatment with vein 1 is close surveillance, okay? So close follow-up lang for vein 1. Surgical therapy is the mainstay of vein treatment because it permits histologic diagnosis, and the foci have been detected in up to 28% of specimen. So what type of surgical therapy can be local excision, maliit lang, or yung vein lesion lang, partial vaginectomy, total vaginectomy, tatanggalin yung buong vagina for extensive and persistent disease. Complications are as follows: shortening or stenosis of the vagina due to wide local excision. Okay? Now let's go to vaginal cancer. Okay? It is very uncommon, very rare. 1 to 2% of gynecologic malignancies, usually upper third of the vagina, is involved. Usually, they come from primary malignant neoplasm of the cervix. Okay? So, you need to examine the cervix if it has lesions. If it has lesions in the cervix, then it's most likely cervical cancer that is metastasizing to the vagina. And if you have a vaginal lesion, make sure that there is no lesion in the cervical tissue. Okay? It occurs in the 7th to 9th decade of life of the woman, okay, in more than 50%. Okay, the proposed etiology of vaginal cancer as follows. Proposed mechanism for developing vaginal cancer with remote history of cervical cancer. So usually they are drop cancers from a cervical cancer. Occult residual disease, radiation-induced tumorigenesis, and new primary cancer in a high-risk individual. So those are the mechanism why cervical cancer can transform to or can metastasize to a vaginal cancer. Vaginal intraepithelial neoplasia is also a cause of vaginal cancer. Usually 16, HPV 16 is the most common associated with vaginal dysplasia. And 3 to 7% progress to invasive carcinoma despite treatment of your vein. Chronic vaginal irritation and is also identified as one of the possible etiology of vaginal cancer, and the mechanism of this is not well understood. Okay? New vaginal lesion 5 years or more after treatment cervical cancer constitutes a new primary vaginal cancer. For example, you have a patient with cervical cancer. You need to have no evidence of recurrence for cervical cancer. Tapos biglang after 5 years, after 5 years ng cervical cancer siya, there is a new lesion in the vagina, then that fulfills the criteria that it can be considered as a vaginal cancer. But if it is within 5 years from the cervical cancer disease, then it is not vaginal cancer. Risk factors for your vaginal cancer: history of radiation therapies. Usually they are vaginal sarcomas. Diethylstilbestrol intrauterine exposure. Kailang konti na lang yung mga tao na kasi it has been already phased out noong 1970s or 80s. Usually, the ethylstilbestrol or intrauterine exposure predisposes a patient to have clear cell adenocarcinoma of the vagina. Human papillomavirus infection in the past is a risk factor as well. What is the presentation of vaginal cancer? Abnormal bleeding, discharge that is foul-smelling, pain, urinary frequency, and constipation because of the mass effect. Urinary frequency, it's because of the mass effect of it. Primary vaginal cancers usually occur as squamous cell carcinomas in women older than 60 years. Malignancy must arise in the vagina and not involve external cause of the cervix superiorly or the vulva inferiorly. You need to rule out vulvar cancer. You need to rule out cervical cancer. Okay? Vaginal cancer is usually a wastebasket diagnosis. You need to rule out mga more famous malignancies such as vulvar or cervical cancer. Okay? You should do adequate pelvic examination, vaginal colposcopy in patients that have normal pap smear and no gross abnormality. Painless vaginal discharge, often bloody, is the most frequent symptom of vaginal cancer. Postcoital or postmenopausal bleeding, urinary symptoms, also tenesmus, and sometimes 5 to 10% of these patients are asymptomatic. Wala silang symptoms. Okay? Vaginal cancer primary should not involve surrounding organs. Okay? Nasabi ko na kanina na you need to clear 5 years of cervical cancer to say na vaginal, that this is a new cancer. No? And this is a new vaginal cancer. Okay, this is the staging of vaginal cancer. Okay, I think this is not important anymore because of the rarity of the disease. Okay, age prognostic factors would be age at time of diagnosis. Baka masyado ng matanda. Performance status, meaning the woman is not functioning very well anymore. So, pag ganon, pag bedridden siya, there is a less chance for survival. Tumor histology, some are aggressive, some are not. Vaginal melanomas and sarcomas have the poorest prognosis. Age, tumor location, tumor size, more than 4 centimeters gives a patient poor prognosis. Vaginal cancer management, early stage, we do wide local excision or radical hysterovaginectomy with groin node resection. For more advanced diseases, radiation concurrent with chemotherapy, followed by limited surgery and or brachytherapy. Okay? So how do we prevent? And how do we prevent? What's the primary prevention and secondary prevention for vaginal cancer? We counsel patients, our kids, delay sexual debut, having mutual monogamous relationships, practicing safe sex, stop smoking, and HPV vaccine. Okay, as well as because HPV has been identified as a culprit in vaginal cancer and vulvar cancer. Okay, and the cause of cervical cancer is sexually transmitted virus called human papillomavirus. There are many HPV types and only some cause cancer. HPV infections, even high-risk types, usually go away without treatment. Low-risk HPV types can cause genital cancer. Okay? And the high-risk types cause most abnormal pap smears, precancer, and cancer of the cervix, vagina, and vulva. Okay? It's not only about cervical cancer when we talk of HPV. Marami pang ibang cancer. Vulvar, vaginal, in male, penile cancer, oropharyngeal cancer for both sexes, and penile cancer for both sexes. Okay? The cause of cervical cancer, yan, is HPV pa rin. There are so many strains right now. And the myth busting is that the best protection against cervical, vulvar, and vaginal cancer would be HPV vaccine, which should be the HPV vaccine. Okay? HPV isn't that common. False. Very common siya. HPV only causes cervical cancer. False. HPV vaccine isn't effective. It is very effective. Okay? Your HPV vaccine right now, the one it can give you 97%, as high as 97%. The HPV vaccine is just for women. No, you can give your HPV vaccine also for your male patients. You only need the HPV vaccine if you're sexually active. False. Just because you aren't now doesn't mean you'll never have sex. Getting the vaccine protects you for life. Okay? You'll never know kung anong mangyayari sa future, so might as well do vaccination habang maaga pa, baka magsisi tayo sa bato. Okay? Key point summary for vaginal cancer. Primary cancer of the vagina is less common than uterine corpus, ovarian, and cervical cancer. Most vaginal tumors are squamous cell carcinomas, but melanoma, sarcoma, adenocarcinoma, and other serologic types also occur. Although primary vaginal cancer is rare, metastatic disease to the vagina or local strengthened from adjacent gynecologic structure is not uncommon. So usually they come from cervical malignancy. As a result, the majority of vaginal malignancies are metastatic, often arising from the endometrium, cervix, vulva, ovary, breast, rectum, and kidney. Vaginal metastases may occur by direct extension. For example, cervix, from the cervical niche, cervical cancer, vulvar cancer, endometrial cancer, or by lymphatic or hematogenous spread. For example, breast cancer, ovarian cancer, and renal cancer. Okay? So this is the summary for your vaginal cancer. Ang very important dyan is that vagina need to rule out cervical cancer and vulvar cancer. And it is also HPV related. Okay? So here are my references for vaginal cancer. Okay? So that ends the vulvar and vaginal pre-malignant and malignant conditions of the vulva and the vagina. They're very rare. Ano ang chances na lalabas sa exam? It can pa rin, no? So you need to know these basic things, okay? And that's the end of my lecture, and I hope you learn something from lecture on vulva and vagina. And I hope my discussion will be a great help. At sana pumasa po tayo sa ating exam. And have a great day. Thank you.
Okay, so wait lang. Do you have any questions? Anyway, if you have the Google Meet. If you have any questions, just message me now. You know my SOCMED accounts. Also, do you want a PDF file of my lectures?
Yes po.
Sige, I'll just send you a link. Google Drive link, no?
Yes po.
When is the exam?
The exam is this Saturday po, November 20.
This Saturday na?
Yes po.
Okay. Sige, I'll send it today.
Yes po. Thank you po.
Okay, so if you have questions, just message me na lang. Okay, thank you.
Thank you po.
Thank you.
Thank you po.